Good afternoon, everybody. This is Mark Lockwood. We're going to go ahead and get started at 2. If you all can, for those who already are attending the webinar right now, if you can go ahead and introduce yourself via the chat box, into your first name, last name, and the organization in which you're a part of. And again, we'll be starting at precisely 2 o'clock. Thank you. We'll be going ahead, getting ahead and starting shortly. Thank you. Okay, everyone, the time is now 2 o'clock. We're gonna go ahead and get started. Happy Monday, everyone. I hope that you all are doing well today on this lovely Monday afternoon. My name is Mark Lockwood, and on behalf of the Center for Harm Reduction Services, I would like to thank you all for attending today's Maryland Overdose Response Programs training of trainers. Again, my name is Mark Lockwood, and I'm the Harm Reduction Programs Manager here at the Center for Harm Reduction Services. And I'm here presenting today with my colleague, Elizabeth Murphy, who is our center's Overdose Response Program Community Engagement Manager, as well as Mira Corey, who is associated with the Maryland Harm Reduction Training Institute. And next slide, please. And just a little bit of an overview of today's presentation. We'll have an introduction, which will just go over the mission and vision of the Prevention and Health Promotion Administration, the scale and scope of the work that we do here at the Center for Harm Reduction Services, and general harm reduction principles. Then we'll go into the ORP training curriculum, as well as the required reporting. And then we'll have a break for questions. And then we'll go into part 4 of tailoring the trainer, and then lastly, we'll wrap it up with additional questions that you all, as participants, may have. Next slide, please. So the purpose of this training is to, this training would, 1, provide information about the overdose response program, 2, would provide information about overdose death crises in Maryland, 3, it'll provide a curriculum for overdose response program trainings that meet the statute requirements. 4, it'll provide suggestions for risk reduction messaging. 5, it'll provide guidance on reporting and dispensing requirements. And then 6, lastly, it'll provide suggestions for tailoring trainings that meet your audience. And of course, the intended audience for today are all overdose response programs. I also want to note that while there is no trainer certificate for overdose response training, that this training provides individuals with all of the information needed to effectively deliver their own trainings. In this training, you'll also learn about laws governing ORPs, how to treat someone suffering from an overdose, as well as the required reporting for authorized overdose response programs. Some of those learning objectives that we'll go over is that participants will be able to identify 8 signs and symptoms of an opioid overdose. So list 5 key steps to respond to an opioid overdose, to identify 3 ways to prevent opioid overdoses. You'll also learn how to conduct a brief training, and then lastly, identify 3 ways to tailor overdose response trainings to a variety of audiences. Next slide, please. And just a few logistics and housekeeping rules. Again, because it is a recorded call, I just ask that everyone keep their lines muted. And if you have any questions in the middle of the presentation, we'll go ahead and I ask that you all just enter them in the chat box, as well as introduce, as it pertains to introductions, again, please, if you have not done so already, to just list your first name, last name, and the organization in which you're a part of. But before then, I also want to introduce my team, who's also on the call. So aside from Elizabeth Murphy, who is my co-presenter, Liz is our ORP Community Engagement Manager. We also have Dana Hellman, who's my Deputy Chief. I actually see her on the bottom left screen here. We have Aaron Russell, who is our Centers Chief. We have Marie Stratton, who is we're grounding our response manager on the call as well. We have Cal Kinney, who is our operations manager. We have Leslie Evans, who is our events manager. And then last but not least, we have Jess Nesbitt, who is our provider partner specialist, and will also be managing the chat box for today. Thank you all so much. Next slide, please. And so just the introduction, next slide. So the mission and vision of the Prevention and Health Promotion Administration is to protect, promote, and improve the health and well-being of all Marylanders and their families through the provision of public health leadership and through community-based public health efforts in partnership with local health departments, providers, community-based organizations, and public and private sector agencies, giving special attention to at-risk and vulnerable populations. The Prevention and Health Promotion Administration envisions a future in which all Marylanders and their families enjoy optimal health and well-being. Next slide. And so just to tie into that, the Center for Harm Reduction Services fits within that scope. And we too have created our own strategic goal and vision for this fiscal year, where the center's strategic goal is to reduce substance-related morbidity and mortality by optimizing services for people who use drugs. Here at the center, we also envision a Maryland where, 1, healthcare and social service systems meet the needs of people who use drugs in a comprehensive community-based manner. 2, people who use drugs have equitable access to high-quality care. And 3, services provided to people who use drugs are ultimately free from stigma and discrimination. Next slide. And of course, we wouldn't be a Center for Harm Reduction Services without thinking about the scale and scope of a harm reduction approach. And so, of course, a lot of us know already what harm reduction is, but for those who might not know, harm reduction is, 1, to minimize the negative effects of drug use for people who use drugs, their families, and their communities. And it's important to think about what might harm reduction look like in practice. Well, 1, harm reduction is rooted in a commitment to public health and human rights, and ultimately to combat stigma. It also recognizes the reality of trauma, racism, poverty, class, and sex-based discrimination as contributing factors. It also empowers people who use drugs to keep themselves as safe as possible and to meet them where they are, as well as to aim to attain any positive change. Next slide. So now we're going to go into the scale and scope of the Overdose Response Program. So the Overdose Response Program was established by statute in 2014 and revised by the HOPE Act in 2017. And it's important to note that regulations were also revised most recently in 2019. And some of the features of the Overdose Response Program is that it provides a mechanism for naloxone to be dispensed outside of a healthcare setting. It also allows entities to become authorized as ORP training entities. It allows them to partner with the prescriber and have the prescriber issue a standing order prescription whereby any employee or volunteer of the organization can dispense naloxone to trainees without the prescriber ever being present. Next slide, please. Within the scale of the Center for Harm Reduction Services, us at the center, we actually process new applications and authorize entities as overdose response programs. We manage and monitor all of the ORP reporting that's required by our statute, as well as providing technical assistance and purchasing naloxone for eligible ORPs to distribute. And also we ensure that naloxone is reaching people who are most at use for overdose, as well as filling in gaps by providing naloxone training and dispensing naloxone into the community. Some of the benefits of becoming an ORP is that it allows you to dispense naloxone outside of that patient-provider partnership. Sorry, tongue twister. It allows employees or volunteers to dispense naloxone on behalf of a prescriber. And it's important to also note that naloxone can be dispensed to an individual who does not have a prescription, keeping in mind that the ORP's standing order acts as a prescription for all of the trainees. Also, if your organization is a not-for-profit, it allows you to receive naloxone from us here at MDH free of charge. If you currently send patients to a pharmacy to get naloxone, it eliminates tongue twister, a step that many patients don't follow through on, and allows you to put the medication directly into that patient's hands. As well as one key benefit that we have here at the center is that it also allows for other ORPs to connect through monthly collaborative calls where they can build community, as well as through a listserv as well. Next slide, please. Some of the requirements for authorized ORPs is that monthly reporting based on the number of people trained, as well as the number of doses of naloxone spent, including aggregate demographic information when it's available. It allows you to also reauthorize every 2 years, where that particular ORP would resubmit application documents with updated information, as well as some other requirements so that you would have to notify the Maryland Department of Health of any changes to the ORP's point of contacts, as well as conducting trainings that that cover the required topics, as we'll discuss later on today. Some other requirements is particularly around training. So the training provided by the authorized overdose response program must include, at minimum, information on all of the following topics. It would be 1, education on recognizing the signs and symptoms of an opioid overdose, training on responding to an opioid overdose, the proper use of administration of naloxone, as well as proper rescue breathing techniques. It should also cover the importance of contacting emergency medical services, which we'll discuss later as well as the care of an individual after administering naloxone, and then any other required topics by the department. And I also want to note that while there's no mandated PowerPoint presentation for the training, however, the content of your presentation must contain the aforementioned topics in order to be in compliance with the Maryland Department of Health. Thank you. Next slide. So now I'm going to turn it over to my Overdose Response Program Community Engagement Manager, Elizabeth Murphy. Thank you all so much.
So good afternoon, everyone. I'm glad you could join us. We're going to begin this section of the training with a brief overview of the overdose death crisis in Maryland. Next slide. So it's important to know what is happening in your geographic area. And while it's not required of ORPs, this information is helpful for your trainees to have. Of course, you must consider the setting of the training. So listed, we will have several links that you can access these current statistics. Next slide. So the data in this presentation is from the latest Unintentional Drug and Alcohol Intoxication Deaths Quarterly Report from the Opioid Operational Command Center. During Q2 of 2020, Maryland saw increases in fatalities related to almost every substance. Fentanyl continues to present the most serious challenges as it plays an increasing role in the majority of opioid-related deaths and all intoxication-related deaths in the state. Equally concerning is the recent spike in alcohol-related deaths. There were 287 alcohol-related deaths in 2020. This is an increase of 34.7%. Drastic increases in alcohol and non-opioid substances are evidence of general increases in substance use due to the despair caused by COVID-19. These effects have been broad and far-reaching. Next slide. So the total number of unintentional intoxication deaths occurring in Maryland from 2011 through Q2 of 2020, and I'd like to focus, other than in 2019 where we saw a slight decrease, already in Q2 of this year, we've seen 1,326 unintentional intoxication deaths. And I always like to break this down. That number represents 221 people a month in our state who have died of unintentional intoxication deaths. Next slide. So the total number of opioid-related fatalities in Maryland from 2011 through Q2 of 2020, again, we see the slight decrease last year, but already in Q2, we have already had 1,187 opioid-related fatalities in our state. This represents 198 people per month. Next slide. So the intoxication deaths by opioid type in Maryland, 2019 versus 2020 through the second quarter. Again, you can look at fentanyl, 1,100 people. That represents 183 people a month in our state. Heroin continues to show a slight decrease over the last few years. Of concern is prescription opioids, where we have seen an increase to 214 people, and this is 8.1% higher versus 2019. Next slide. So intoxication deaths by substance. Again, 2019 versus 2020 through the second quarter, we can see that with all opioids, there's been an overall 9.4% increase. We look at cocaine deaths, that is a 13% increase. Alcohol deaths, again, 34.7% increase. Benzodiazepines are showing a 24% increase. Methamphetamines, which is concerning, is showing a 122.2% increase. And phencyclidine, we've seen a slight decrease of 8.6%. And for people who aren't familiar with phencyclidine, it's angel dust or PCP. Next slide. So deaths involving substances mixed with opioids. Again, what this shows us, it indicates a driving force behind all of our fatalities are due to polysubstance use. Next slide. So while all 24 of Maryland's local jurisdictions reported opioid-related intoxication fatalities in the first month of 2020, in the first half of 2020, the substantial growth in fatalities was not experienced evenly throughout the state. Many jurisdictions and regions reported large increases, while others saw significant decreases. Baltimore City, Baltimore County, and Anne Arundel County experienced the highest numbers of fatalities, collectively accounting for 59.3% of all opioid-related deaths in Maryland. Next slide. And here's just another view. Other jurisdictions that reported large numbers of opioid-related fatalities included Prince George's County, Washington County, Montgomery County, and Cecil County. These jurisdictions had 87, 57, 51, and 43 fatalities, respectively. Prince George's County, in particular, reported the dramatic growth in opioid-related fatalities, with the largest numerical increase of any county in the first 6 months of 2020 as compared to the same time frame last year. The 87 total opioid-related fatalities reported in Prince George's County represents a 135.1% increase. In contrast, Baltimore City continued its recent trend of decreasing opioid-related fatalities with 35 fewer deaths, or a 7.6% decrease in the first half of 2020 compared to the first 6 months of 2019. Next slide. So So I apologize that this slide is not up to date. It's the most recent one I have through 2018. But I also want to say we're continuing to see this, we're seeing this trend continue. So if we look at the number of drug and alcohol intoxication deaths by age group, we go to 2018, we can see that the 55 and older, there have been 618 drug and alcohol intoxication deaths. We're continuing to see that trend across the state. And so it's something that we ask you to pay attention to, of how do we reach out to the population of people 55 years and older. Next slide. So this shows us naloxone administrations that have had a positive result. And in Q1, we can see a large decrease of 14.7% in naloxone administrations. It's slightly smaller in Q2 with a 9.8%, but we can see that COVID-19 really has, we believe, affected naloxone administrations across our state. Next slide. So non-fatal opioid-related emergency department visits. Again, we're showing a significantly fewer emergency department visits. In Q1, it was a 26% decrease. In the first half of in both quarters, it was a 26% decrease. We can see in Q2, it's risen slightly. But again, we believe that it's people are afraid to go to an emergency room because of COVID-19. Next slide. So just a little more on fentanyl. Fentanyl continues to be involved in the vast majority of opioid-related fatalities. There were 1,100 fentanyl-related deaths during the first 6 months of 2020. This is an 11.9% increase compared to the first half of 2019. It has been involved in 92.7% of all opioid-related fatalities in the first 6 months of 2020. And I'll repeat that, 92.7% of all opioid-related fatalities in the first 6 months of 2020 versus only 8% in 2013. So fentanyl may be sold with heroin. People may or may not realize that there is fentanyl mixed with their heroin or in their other drugs. Next slide. So this picture really is worth 1,000 words. This is on the right, a potentially fatal dose of fentanyl. It literally takes grains. And on the left is a potentially fatal dose of heroin. Next slide. So here are some examples of prescription opioids that you might want to share if you're doing a public training in a large group. And I'm not going to read all of those, but still people want to know. They're still unfamiliar with what exactly is an opioid. So here we have listed examples of prescription opioids. Next slide. So in examples of illicit opioids, heroin, non-pharmaceutical fentanyl. It's illicitly produced. It's a synthetic drug. Its pill form is packaged to look like prescription medications. Its powder form looks similar to heroin. Fentanyl and heroin can be a deadly combination. Fentanyl may be hundreds of times more potent than heroin. And so often people will confuse these two fentanyls as the one that people are given when they're in hospice or what we're given when we have surgery in a hospital. And this is not what we're talking about. This is an illicit fentanyl that is being produced that's driving our overdose death rates. Next slide. Next slide. So the ORP training curriculum overview, again, recognizing an opioid overdose. What is an opioid, which again is optional, the signs and symptoms, how to respond to an opioid overdose, using naloxone, rescue breathing, contacting EMS, care of an individual after administering, tips for preventing opioid overdose, and resources will be covered in this section. Next slide. So recognizing the signs of an overdose. So what happens? An opioid overdose happens when a toxic amount of an opioid alone or mixed with other opioids, drugs, and/or substances overwhelms the body's ability to handle it. Many opioid-related overdoses are a result from mixing prescription painkillers or heroin with benzos, cocaine, and/or alcohol. Next slide. So what leads to an overdose? Begins as a respiratory event with respiratory failure, which leads to a lack of oxygen in the blood, which affects our vital organs like the heart and brain begin to fail, which leads to unconsciousness, coma, and death. Next slide. So these are the signs and symptoms of an overdose, and this is part of the core curriculum that must be taught. So slow, shallow, or no breathing, unresponsive, unconscious, loud snoring or gurgling noises, very limp body, lips, fingertips turn blue or gray, the skin is pale, gray, or clammy, pulse is slow or erratic. Next slide. So how do we respond to an overdose? So what is naloxone? Naloxone is a medicine that reverses an opioid overdose by restoring breathing. And I heard not long ago, someone said it at a conference, where there is breath, there is hope. This medication restores breathing. It wears off in 30 minutes to 2 hours, is safe for children and pregnant women. It can be delivered intramuscular, intranasal, or intravenous. It has no potential for misuse, no side effect on someone who hasn't taken opioids. It has no effect on someone who hasn't taken opioids, and its side effects are minimal and rare. Naloxone is only effective in reversing overdoses involving opioids. Next slide. So here's a simulation of an overdose. These are our brain receptors, and an overdose occurs when too many opioids bind to our receptors and impact our breathing. So next slide. So what happens when we give a person naloxone is the naloxone comes in, it bumps off the opioids from the brain receptors and replaces them. Naloxone has a stronger affinity for the receptor than the opioids, but it only knocks them off for a period of time. Next slide. So I'm going to actually stop here. And I always find this part difficult because I'm used to standing up in front of an audience, as I'm sure all of you are when you're doing a training. And we'll go through the slides when I'm finished. I'm just going to talk through how to respond to an opioid overdose. So step one, the first thing we want to do is get a person's attention. So we want to grab them by the shoulder, shake them, call their name if you know their name. If there's no response, make a fist, rub it firmly up and down the middle of the person's chest. It's called a sternum rub or a chest rub. If there's no response, we want to immediately call 911, tell them our location and the person's symptoms. Step three, we want to give the medication. We want to peel back the package to remove the device, place the tip of the nozzle in either nostril, it doesn't matter which one, until your fingers touch the bottom of the person's nose and press the plunger firmly to release the first dose. As soon as you do that, throw it away because it's finished. So while you're waiting the 1 to 3 minutes for the naloxone to work, you want to get the person flat, tilt their chin back, make sure there's nothing blocking their airway. And this part is really important. And I'm hoping all of us are also getting face shields when we're giving out NARCAN, especially during COVID-19. So we tilt the chin back, make sure nothing's in the airway, place the face shield over a person's face, pinch their nose closed through the face shield, and cover their mouth with your mouth below 2 regular breaths. Then give 1 breath every 5 seconds. So it's 2 regular breaths, 1 breath every 5 seconds. If there's no response, give them the second dose. You can remember that you can't really give too much you really can't give too much NARCAN, but you do want to wait the 1 to 3 minutes in between doses, and you want to continue doing rescue breathing. If for any reason, step 5, if for any reason that you have to walk away from the person, even if it's to go in the other room to get more NARCAN, you always want to place the person in the recovery position with their face and head turned to the side, their top hand placed under their head, their top knee bent to support the body. Next slide. So again, we're just going to look at what I just went over quickly. So step 1, shake the person, rouse and stimulate. Next slide. Step 2, call 911, because we always want to remember that naloxone is only temporary, and still many people don't realize that. And so when we take opioids, any opioids that are still in our bloodstream, even though we've given NARCAN and the NARCAN has replaced the opioids in our brain receptors, they're still running, those opioids are still running around a person's bloodstream. So in that 30 minutes to 2 hours when naloxone wears off, anything in the body, a person doesn't have to use any more drugs, can reattach to our brain receptors and a person can overdose again. So we really have to emphasize that naloxone is only temporary. And the other things, the person may have complications from other health problems. You might not have enough naloxone with you. Sometimes the drugs that we're seeing are so strong that I'm hearing reports that it's taking 3, 4, 5, and sometimes 6 doses. Most people will only have 2 doses of NARCAN with them. And it could be a non-opioid overdose. Next slide. So again, this is what the majority of our overdose response programs have, is the 4 milligrams of nasal NARCAN. Will also, some folks do have intramuscular, and we'll go over that at the end of this. Next slide. We're not going to read. Most of you are familiar with the packaging and how to peel it back and how to remove the naloxone. Next slide. Next slide. And again, rescue breathing. Next slide. So just a note, if the chest, you just go back. So if the chest does not rise, to make sure, you know, when you're doing rescue breathing, that you look at the person's chest. If it doesn't rise, retilt their head and start over. Next slide. So again, it's so important that we care for the person, that we try to keep them calm, that we try to get them, you know, if they can't sit up, make sure they're in the recovery position. Next slide. Again, here's a picture of the recovery position. Next slide. So here are instructions for injectable naloxone. So those of you who use this, you pop off the flip top from the naloxone vial, insert the needle into the vial, and draw up 1 cc of naloxone into the syringe. Use an alcohol wipe to clean the injection site. It can be injected in the shoulder, thigh, or buttocks. Inject the needle straight into the muscle, through clothes if necessary, then push the plunger. Do not inject naloxone into a person's heart, chest, or back. Next slide. And again, these are examples of where you can inject naloxone. Next slide. And so what's important too is if you administer naloxone, to report it to the Poison Control Center or report it directly, any naloxone administrations, to us. Here is the link. I know most of you also have it, but this will be included in the PowerPoint, the naloxone use report. You can share this link publicly. So if you're doing a training, you're giving out NARCAN, you can make sure they have this because they can report themselves if they've used it. Next slide. So I think at this point, we're going to turn it over to Mira, who from the Maryland Harm Reduction Training Institute, to go over some tips for preventing an opioid overdose.
Good afternoon, everyone. Oop. Looks like someone took over presenting. Thanks, Dana. Again, my name is Mira Corey, and I'm from the Maryland Harm Reduction Training Institute, and I'll be doing this section on tips for preventing opioid overdose. Next slide, please. Okay, so harm reduction, which Mark mentioned earlier, actually equates to opioid overdose prevention. They are synonymous. And when it comes to opioid overdose, there are several risk factors, as you can see listed here. I won't go through the entire chart, but some of the key risk factors are the quantity, and a strategy to reduce that risk is to start low and go slow, which means using a smaller amount than usual and to inject it slowly to see how it affects you. Another risk factor would be using alone, and to manage that risk, we would suggest as a harm reduction approach would be to not use alone, or to let someone know where you are going to be using and to leave the door open or unlocked. And if you're using with others, take turns using instead of everyone using at one time, and make sure that you have naloxone. Um, so that, and if you're taking turns, that means the person who is not using would be able to administer naloxone and to call for help if needed. Um, and lastly, a prominent risk factor is mixing drugs, also called polydrug use. And a strategy to reduce that risk is to try not to mix opioids with alcohol and or benzos. Again, NARCAN only works on opioids. So if there are benzos in your system, um, you could potentially be overdosing on that as well. And the NARCAN will only work on the opioids. And also using one drug at a time or using less of each drug is another strategy. Next slide, please. So some resources and information. Next slide. So now we want to talk about the Good Samaritan law in Maryland. This law protects individuals who are assisting in an emergency overdose situation and those who are experiencing an overdose from prosecution and arrest for misdemeanors. The law does not protect people who are strictly witnessing the event, the medical emergency, if they are not helping. There's a link to a fact sheet in your PowerPoint slide that you'll be able to access later with a fact sheet about more on the Good Samaritan law. Next slide, please. So the Good Samaritan law protects people from criminal arrest, charge, or prosecution for the following misdemeanors. So possessing or administering a controlled and deadly substance, drug paraphernalia charges, controlled paraphernalia charges, underage possession of alcohol, obtaining alcohol for underage consumption, or furnishing for or allowing underage consumption of alcohol. The Good Samaritan law protects from the violation of a condition of pretrial release, probation, or parole. And these protections only apply if the evidence was obtained solely because of the act of seeking medical assistance. So the thought behind the Good Samaritan law is that we don't want criminal arrest to be a reason that someone does not help another person in the midst of an opioid overdose or an alcohol-induced emergency. Next slide, please. So, how to get naloxone. You can request naloxone at a participating pharmacy throughout Maryland under the statewide standing order. The pharmacy can bill your insurance even when using the statewide standing order. You do not need a prescription. You do not need to prove that you were trained. If you have difficulty accessing naloxone at a pharmacy, please let the Maryland Department of Health know by contacting the email address below. Also, you can receive more information on how to get naloxone through the two links below for an overdose response program or for a syringe services program. And those links will also be available in your PowerPoint presentation. Next slide, please. When you do your own training, it may be helpful to include information about local resources in your ORP training, such as the local syringe services programs, locations, hours, and contact information, information on social services, on resources for family and friends of people who use drugs, and information on how to get a refill of naloxone. These will be incredible resources to give to people so that they continue on disseminating these tips and tricks to their networks and their groups. Next slide, please. Okay, and that's the end of the ORP training curriculum. I do believe I am turning it back over to Liz.
Yes, you were. Thank you, Mira. So next slide, Dana. So before I begin this, I just want to say that I know that the statistics and what I've shared are really disheartening. And they're a reminder that we are struggling with 2 epidemics right now in our state. But I would also like to thank all of you for your hard work and your commitment to saving lives, especially during this trying time of COVID-19. And many of you have either spoken to me or received an email concerning missing or late reports. And you all do so much good work. But if you do not report it, then we cannot see the work you are doing. We cannot see the efforts you are making. And I always like to tell myself that behind every report I have to do is a human being. It's a human being that we're trying to help and trying to provide services for. And we still need to be able to show that our programs are effective. So I want to begin with the overdose response training report. Maryland law requires ORPs to report aggregate data monthly to MDH if any trainings were conducted. The center requires ORPs to report on the following for each training: the training date, the jurisdiction and setting, the number of individuals trained, the aggregate number of individuals trained in each demographic category, if available, the sex, ethnicity, race, and age, the aggregate number of individuals trained in each reason for training category. And again, we get a lot of questions about this particular category for reason for training. And I just want to say that remember that our target population, though we want to train anyone who is interested in receiving NARCAN, but our target population is social experience. It's people who use drugs, friends of people who use drugs, people who are likely to use that NARCAN. So we just want to emphasize that social experience is something that we look closely at when you're doing trainings. So if you're dispensing naloxone, the number of doses dispensed, whether or not it's an initial dose or a refill. And if you're dispensing fentanyl test strips, the number of fentanyl test strips that were dispensed and the number of people receiving the test strips. Next slide. So again, overdose response programs submit these monthly training reports. And I know most of you have the link to the new web form, but again, it will be in the PowerPoint. A reporting guidance document is also available in the PowerPoint. ORP should submit 1 report for each group training conducted. One-on-one trainings may be batched and submitted as a single entry each month. So if you're going out into the field and doing outreach and you've met 20 people in 20 different locations, you can put them all together in one batch, pick a date, and enter them as a single entry. So report the naloxone doses dispensed. And again, this is another area where we see some conflict sometimes. We have so many names for one Narcan kit, or whether or not it's a unit or we call it a box. But the picture that you're looking at, the most of you have, for me, I call that a unit. That unit has, you can see it says 2-pack, it has 2 doses. So it has 2 4-milligram doses of nasal Narcan. So if you train one person, because we don't split up the medication, and you give them 1 unit of NARCAN, you count that as 2 doses when you report. Next slide. So in here, again, is the training report that I'm sure you're all familiar with, but we just thought we would put it up here. You choose your entity name, the event date, the event location. Next slide. And again, once you choose initial, because people say, well, I don't see where to put the other demographics, the ethnicity and the age. So once you choose initial training, dispensing, the box will drop down, and then you'll see ages, and then you'll see ethnicity and those things. If it's a refill, you don't have to fill out all that information. Next slide. So the trainee registration form that MDH has created, it's to assist overdose response programs in collecting this information required for reporting. Overdose response programs can use this form to collect information from trainees and then aggregate the information from the form to submit through the MDH form. Trainee registration forms are for overdose response program records only and should not be submitted to MDH. MDH does not collect any personal identifying information on trainees. So with the new form, web-based form, you no longer have to email or fax us copies of these reports. Next slide. So again, here is a copy of the trainee registration form. And again, I'll point out at the bottom, it asks for your prescriber name, the name of your overdose response program, the zip code where the training is taking place, and important is to include the naloxone lot number, what the expiration date is of the medicine, and how many doses you gave. And again, over here on the right, I'm sorry you can't see, but I'm pointing, the fentanyl test strips if applicable. Next slide. So again, this is just an example of a nasal NARCAN kit. So 2 doses of NARCAN, rescue breathing mask, any kind of educational inserts. It's really up to you what you want to put in it. I know in ours, we have the instructions of how to use naloxone, how to administer it. We have gloves, we have a face shield, we put a fentanyl fact card, but that's really to be determined by your organization. Next slide. So if you're distributing intramuscular naloxone kits, the 10 milliliter vials of naloxone includes several syringes for 1 syringe per 1 milliliter injection. Any option is okay as long as the point is 1 inch long to reach the muscle. Intramuscular syringes are larger gauges than insulin syringes. And if you are distributing 1 milliliter vials of naloxone, include at least 2 vials in the kit with muscle syringes. Again, you want to make sure that you have alcohol pads, rescue breathing mask, gloves, and anything else you determine with your staff that you would like to put in the kit. Next slide. Oh, I just want to mention before I talk about the labeling, the other thing that I always like to put in the kits that we give out is a copy of the Good Samaritan law, because sometimes people feel confident, more confident if they have that, and the police show up and they feel hassled that they can actually pull something out and show them. So I always include a copy of the Good Samaritan law. Next slide. So labeling. If dispensing NARCAN in its original packaging, overdose response programs should label the kit's medication with the following: the name and address of the dispensing ORP, the date it was dispensed, or the date of the standing order was issued for your organization. And it might be easier to put the date the standing order was issued. So the name of the prescriber, the licensed healthcare provider who you have an agreement with, who issued your ORP standing order. Next slide. So now we're going to take a break for questions. And thank you all for being patient. It was a lot. It's a lot to go through.
Hey, this is Jess. There's a couple of questions in the chat. do you want to go through those first, or would you like folks to unmute and ask questions?
Sure. Why don't we go through what's in the chat box first, and then people can unmute and ask, and then we're all available to answer. So.
Awesome, great. And I think, if there are questions that we're not able to get to, we'll follow up with you about those. I'm taking a note. So there are a lot of good data questions. I'm going to hold those since that's not like the main focus of this presentation. All really important questions. But the first question was about how should we tell people to respond to an overdose during COVID-19?
Do you all mind if I jump in and respond to this one?
Go ahead, Dana.
Okay. I just wanted to say about COVID response, I would defer to your local health department guidance and definitely defer to your ORP prescriber. So that's the provider that you have a agreement with, who issues the standing order for your ORP. So work with your provider and work with your health department to figure out what's the best kind of communication and guidance to be giving trainees around naloxone administration during COVID.
Awesome, thank you. There was sort of a policy question about the Good Samaritan law as well. In the actual text, it looks like of the bill, there's like a strike through. And someone was asking, why is that strike through there?
Yeah, I did take a look at that link. I'm not familiar with that particular revision, but I believe it was Rania. I would be happy to connect with you afterwards, and we can take a look at it together and talk about what that might be, but I'm not familiar with what that revision is off the top of my head. It looks like it's from 2015.
Okay, got it. Thank you. Should we jump into some data questions? What would you like to do, Dana?
Yeah, we can jump into some of those questions, and I will just say as kind of a disclaimer that our center, the Center for Harm Reduction Services, so we don't directly manage the overdose death data. That's Vital Statistics Administration, Behavioral Health Administration that put out those numbers. So the slide deck that we'll share with all of you has links to all of the data sources that we used for the presentation. So you can refer back to those links to get the same data sources that we used and to connect with the administrations that are in charge of that data.
And this is Liz. I'd also like to add that if you are going to use that PowerPoint, you are going to use those statistics, is that you make sure that you stay on top of when they change. They change quarterly. It usually takes a while. We just got those a few weeks ago. So you want to make sure you use updated statistics.
Yeah, thank you both. So some of those questions were, first one is there any data available about whether those who died from opiates were enrolled in any like services? So OTP services or substance use services?
My response would be the same for that specific question, that I'm sure that data is available. We don't have it in-house in our center, so I would connect with the sources, the source information for that.
Okay.
And I would also add, if your local health department, at least if you have a fatality review committee, I know that information is covered during fatality review meetings.
Okay, thank you. I think another similar question, but I'll still ask, is was buprenorphine or methadone seen in people's tox results on fatal and non-fatal overdoses?
Same response.
Okay. Great. And then is there a cross-reference between the saturation of naloxone distribution in counties in contrast to the number of fatal and non-fatal overdoses?
So yeah, I did see that question. I think that was from Anita. So the saturation formula does incorporate the overdose death data from that particular time period. I'm not going to get too much into the saturation formula because there's a lot of background information to go over with that, and we have a limited amount of time today. But I will say that we could have a follow-up conversation about that, and that we do have planned future collaborative calls that will cover the saturation formula and talk more about that. But our center doesn't currently have, for example, like a map that shows the saturation formula in relation to the overdose deaths.
Okay, got it. And it looks like Anita was saying, wondering if it's directly proportional to deaths.
So the formula incorporates the death number into the formula. I think what you might be referring to is like looking at the overdose death data and looking at the naloxone distribution data in the same kind of way. So let's talk offline about how to do that.
Okay. There's a couple more questions that have come up in the chat. Is there enough information to say that COVID-19 has influenced the large jumps in overdose deaths in certain counties?
That's a good question, and definitely Liz and Mark, feel free to jump in. Again, we're not the definitive, data housing center for the overdose data, but from what we've heard, it's been strongly suggested that that is that is related. The COVID-19 pandemic and the increases in overdose death, that does seem to be real. I see another question from Lisa similarly to that. Has COVID affected the dispensing of NARCAN? That is data that we could look at. We haven't specifically seen a relationship yet or looked at that in detail yet.
I think to, again, chime in on Lisa's question, I think sometimes too, this is another reason why reporting is so important, because we're trying to see what is dispensed. And so during the shutdown, and I know we're all working from home and doing different things, there's gaps of 3, 4, 5 months of people not reporting. So we can't get a real picture of what's happening out in the counties. And I know that many of you are still doing limited drop-offs of NARCAN. So again, just kind of reaffirms why those numbers are so important for us. I think the other thing that we try to do as a center, and I don't want to get off subject, is that overdose treatment programs. Yes, Dana, am I saying that right? Yes. OTPs have also been receiving NARCAN from us through many of the health departments being shipping points. So that's another way we've tried to get NARCAN out into the community, because I do believe there is a direct correlation. How much, we don't know. You can see that from the positive naloxone administrations that happened back in those slides on the first and second quarter. You can see a decrease. So it is certainly having an impact.
Thanks, Liz. And again, we definitely encourage you when you're, if you're doing formal presentations, to incorporate your local overdose numbers and data that's specific to your local area. Any other questions related to the overdose response program curriculum or reporting or anything related to that? No.
Yeah, I'm just
Should we continue?
A couple of comments in the chat. Yeah.
Okay, I'm going to go ahead and present my slides again.
Hi, everyone. This is Mira again, and I'm going to be talking to you about how to tailor the training. Next slide. So what we're going to go over when we're talking about tailoring the training, excuse me, is what content is required by law, the training structure, and your target audience. So if we can go to the next slide. So as Mark stated earlier, there is no mandated Maryland Department of Health PowerPoint required. However, your training is required to include at a minimum education on recognizing the signs and symptoms of opioid overdose, training on responding to an opioid overdose, the proper use and administration of naloxone, proper rescue breathing techniques, the importance of contacting emergency medical services, the care of an individual after administering naloxone, and any other topic that is required by the department. These topics are required for your ORP training presentation. Okay, next. So when we're thinking about doing a training, we want to look at it through a trauma-informed approach. And so a trauma-informed approach, which you may have heard of before, recognizes that the impact of trauma is widespread and it strives to avoid re-traumatizing people. So I'm going to pose these questions to the group, and I just want to take one or two answers so that we can keep up with time. But why might the material in this training be difficult for some participants? And as a trainer, how can you be sensitive to overdose-related trauma? You can either put your response in the chat, or you can take yourself off of mute to respond if you'd like.
I see. I'm not sure how to say your name. I'm so sorry. Rania said, be mindful about language. Be present in how people are reacting to the information. If anyone in your class has experienced a friend or loved one overdosing, the event itself can be very traumatizing. Somebody may have lost someone to an overdose.
So yes, all of these things are important to think about when you are speaking to someone about overdose response. Overdose, whether it's someone who has personally experienced an overdose, has had friends or family who've responded to an overdose or had an overdose. An overdose is very traumatizing to the person experiencing it and the person witnessing it. And so you want to take a trauma-informed approach so that you don't re-traumatize people, because when you re-traumatize someone, it can make them afraid to act. And what you want someone to be able to act in a situation of an overdose so that they can help to save a life. Next slide, please. So when planning, you want to consider your audience. You want to think about, what do they likely already know? What will likely be new to them? And what will their concerns be? You can make educated guesses, but remember that you may be wrong. I'm wrong all the time. No one's perfect, but you just want to make an educated guess. Okay, next slide. So when you're thinking about your audience, remember that the training may bring up painful memories or difficult emotions, and be sensitive and respectful of that and those emotions of your participants. You want to model respectful language, which Rania mentioned earlier. And you want to prepare based on educated guesses, but don't make assumptions about individuals. Okay. Next slide, please. So When we think about some target audiences for naloxone training, we have this very exhaustive list provided by the SEEDS project. And my standpoint is that anyone and everyone is your target audience for naloxone training. But as you can see on this list, some folks that we do have, and I'll just point out a few. We have people who use opioids, friends, family members, and associates of people who use drugs, people experiencing homelessness or housing instability, people who use drugs over the age of 55, which Liz pointed out earlier. That number was trending upwards, and people with employment instability. Anyone is at risk of experiencing an overdose and in a position to assist in the event of an overdose. Case in point, from my personal experience, my father just recently experienced knee replacement surgery, and he was on very high opioids. My father is also over the age of 55. Do not tell him I said that. And so I provided a naloxone training for him and his companion, because I'm not around all the time and he's going to be taking this medication. And I wanted both of them to be aware of the situation, because I know that, like this statement says, that anyone is at risk, even if it's just a potentially temporary opioid situation, in his case, after surgery. Okay, so next slide. So, settings. When and where to do a naloxone training? Anywhere. But some settings that are most common are treatment settings, recovery groups and centers, jails, parole and probation, both to the staff and clients, community centers, and they could have drop-in hours. And it's important to be able to conduct an outreach style training in 10 minutes, mostly because people don't have a lot of time. People can only retain so much information, and people already have previous knowledge. And if you're doing a training on the street, say outside of Lexington Market, someone's not going to stand there for 45 minutes to go through a training. You got 10 minutes before it's time to pick up burger cookies and pick up some greens and go home. Okay? So you want to be able to get people in and out, but get them the most amount of information possible, the most important information possible. Next, please. So when we're thinking about people who use drugs, what we need to think about are the systems that they touch. And we're thinking about this in a drug user health framework. And when we think about people who use drugs in this framework, we realize that folks touch all of these symptoms, and I can realize that the print is a little small, so I'll go through each system. So people who use drugs tend to touch the Medicaid system, housing and economic development programs, infectious disease programs, the Bureau of Substance Abuse and Mental Health, the criminal justice system, federally qualified health centers, and countless other systems. But when we think about these systems, all of these systems, one person touches, and with a drug user framework, all of these systems should be working together and collaboratively, with the interest of that person in mind. Okay, next slide. So going back to language, so research demonstrates that the language that we use about drug use can affect the attitudes towards people who use drugs, and that our attitudes in turn impact our actions and our policies. As a trainer, part of your role is to model how to use non-stigmatizing language. Language is key. Language informs your actions and your decisions in our policies. Okay, next slide, please. So here are some examples of respectful language to model. We want to avoid terms like substance abuser, addict, junkie, and instead use terms that we have heard here today, such as person with a substance use disorder or person who uses drugs. We want to avoid the term substance abuse and use substance use or using drugs not as prescribed or substance use disorder. We also want to avoid terms such as clean or dirty and use terms such as negative urinalysis or substance free or a positive urinalysis. Okay. So when we change the language, when we change the conversation, we help to turn someone's thinking into a hero-minded thinking, that they can be a positive impact on themselves and in their community. So by modeling that respectful language, we are really, really empowering an entire group of people who will empower yet another group. Okay, next slide. So talking to clients about overdose. You want to focus on safety and risk reduction. This sends a message that your client's survival is your priority, even during relapse. And using words such as avoidable, preventable, and survivable in the situation of an overdose can be crucial and can change the way someone thinks about an overdose. And say that you want to talk to everyone about overdose prevention. You want to acknowledge trauma of experience in an overdose, and that can play a powerful role in therapeutic engagement and help build even stronger rapport with your clients. You want to emphasize your client's ability to contribute to their community. You want to emphasize that they are a potential lifesaver in an overdose situation, and they can be responders and not just victims. So next we are going to wrap up, and I do believe that I will be turning this over to Mr. Lockwood.
Thank you so much, Mira, for that. And thank you both Mira and Liz for a wonderful presentation. Do we have any further questions that you all may have? Someone, Dana, Rania asks, can they get your email? And yes, that'll be in the follow-up. Do we have any other questions?
I'm not seeing anything in the chat just yet.
No, thank you, Jess. I don't see anything as well.
Should we give a moment for people to unmute and say anything out loud that they'd like to?
Oh, absolutely. I presume no one has questions. Well, if no one has questions, then thank you all so much for attending today's training of trainers. For those who attended today, we'll lead with a follow-up email that'll provide you all with the slide decks, as well as information for contacts, if you all may, in case so that you all can have them at your disposal. Other than that, thank you all so much for attending today, and you all have a lovely rest of your Monday. Have a good one. Thank you.
Thank you.
Thank you, Mark.
Thank you.
Thank you.
Thank you.
Thanks, all.
Thank you, Dana.
Thank you, guys.
Thank you.
Thank you, guys. Have a nice day.